Auzubillahi minash-shaytanir rajeem. Bismillahir-rahmanir-rahim. In the name of Allah, the most merciful and the most beneficent, I welcome distinguished panelists on behalf of Sustainable Development Policy Institute and its 24th Sustainable Development Conference. So this conference we are conducting in the time of COVID-19 scenario, particularly to the Omicron variant, which is now is threatening the world. So I am really thankful to all the panelists, those who have joined us to contribute their thoughts and share their experience and their research with the larger audience and with the participants, those who have joined. I will very briefly welcome my distinguished panelists and let me welcome Dr. Michael from the World Health Organization. He is the emergency head at the World Health Organization. Uh, we welcome Michael, you on board. So thank you so much for being with us. We were expecting that Dr. Palitha was supposed to join this panel as chair, but due to urgency, he has to rush to another city for some official assignments, and then we have Mr. Michael as chair of the panel. So thank you so much, Michael. So let me, ladies and gentlemen, introduce my next panelist, Professor Dr. Shahzad Ali Khan. He is the Vice Chancellor of Health Services Academy, and he has contributed a lot for the health and primary health care system, and of course contributing during this COVID-19. Sir, we welcome you on board for this 24th Sustainable Conference and the panel on health education on health.
Thank you.
So thank you. My next panelist would be Dr. Rana Jawad Asghar sir. He is from Global Health, and he is actually the person who is directly dealing with the COVID challenges, and he is contributing a lot from services point of view and from the advocacy point of view. Sir, we welcome you on this 24th STC. Welcome
Thank you
on
very
board.
much. Thank you very much.
Next, Dr. Yasmeen Sabih Khazi. She is the senior advocacy coordinator with the Ford Foundation and has contributed a lot in terms of mother and child health, family
Shahid,
planning.
Shahid, you need to correct my introduction. I am with Bill and Melinda Gates Foundation.
My apologies, Dr. Yasmeen. Yes, Dr. Yasmine Khazi is Bill and Melinda Gates Foundation. So my sincere apologies, Dr. Khazi, for not pronouncing the organization. So, Dr. Qazi, we welcome you on board for this 24th STC of SDPI.
Thank you.
Thank you so much. Next panelist would be Dr. Adela Rahman. She is assistant professor at Fatima Jinnah Women University, and she has been associated with health education and health research projects, and she will be delivering her research on the health in the context of COVID-19. Thank you so much, Dr. Adela, for joining us. We have Dr. Mumtaz Ali Khan. He is Senior Scientific Officer at the National Institute of Health and directly dealing with the COVID vaccination and contributed a lot in terms of COVID-related research. Dr. Mumtaz Ali Khan, we welcome you on board to this panel. Okay, so last but not the least, Dr. Saadia Mustafa. So thank you so much, Dr. Saadia Mustafa, for joining us. Dr. Saadia Mustafa is directly working with mother and child health related issues, and she is the faculty at Health Services Academy, Islamabad. She has done a number of research in the context of COVID-19, and she will also be sharing the outcome of her research related to the COVID-19 probably maybe the new variant as well. So this is the very brief introduction of all the participants. Thank you so much, audience, those who have joined us from different universities, different institutions, and from the development sector and other organizations. A very pleasant good morning to all of you. So let's start with the very brief opening remarks by Michael. Just a few words as a chair, and then I'll request to Dr. Shazad. So, Michael, over to you. Just a few words.
Yes, thank you, our moderator of the day. Thanks for the introduction. Thank you all panelists for participating in these very, very important discussions. It's the right time, though it's becoming late, for us to think about post-COVID. This thing should have started at the beginning of the outbreak, could be even below. Every time there is an emergency, let's see what is best to do during recovery, because recovery starts from the time emergency happens, so that when the time for recovery comes, we are already in the processes of recovery. So thank you for these discussions, and I hope that our deliberation shall definitely inform the policy dialogue and the response to future emergency like this. Thank you. This is a brief from me, and then eventually could be later I'll read the WRS remarks. So thank you, and you're all welcome.
Thank you very much, Mr. Chair, for this opening remarks. And let me, ladies and gentlemen, introduce very briefly Professor Dr. Shazad Ali Khan. He is the Vice Chancellor of Health Services Academy, has a rare combination of MBBS from King Edward Medical University, and then MBA in finance, and then MS in public health, and PhD in the management program. So this is a rare combination with public health, with business administration, with the management of sciences related to public health. So he has around 30 years of experience in the public health and has the expertise in primary healthcare delivery and development programs. He is a fellow of Royal College of Physicians, London, fellow of Royal Society of Public Health, United Kingdom, member of many other universities and academic councils, member of adjunct faculty of PhD examination committee of many medical universities, and he is the author of 183 research paper and publication. With this very brief introduction, we invite Dr. Shazad Ali Khan to deliver his keynote speech on the topic of this very important webinar on the challenges to primary healthcare and preparedness in the context of Pakistan.
Thank you. Thank you, Shahid. Can you hear me now? Is it clear? Okay. So if you see this topic, primary healthcare, the first thing I would like to mention here is that whatever the concept of primary healthcare is, we in the developing world have not grasped the whole concept of primary healthcare. What we have in Pakistan and many other developing countries, which we call as primary healthcare, unfortunately, that is not primary healthcare. That is selective primary healthcare, and we can easily call it primary care. So there's a difference between primary care and primary healthcare. When you talk about primary healthcare, it is such a I can say broad and diversified field that it includes multiple sectors, multiple interventions available at the doorstep. When we are nowadays talking about universal health coverage, the Almaty Declaration in 1978 defined all these things in the name of primary healthcare. So when we say primary healthcare, 8 components, just imagine the first component is safe water. So in our primary healthcare system, we do not have a safe water provision under the primary healthcare thing. So safe water, sanitation, food and nutrition, health education, antenatal, MCH, all services, and very importantly, family planning. If we see our system, it is common. It is only two. Is based on two things only. One is out of 8, there are 2 things which are related to health. One is treatment of common illnesses, and the other one is provision of essential drugs. So in Pakistan, what primary healthcare we are using in the government sector as well as in the primary care physicians of the private sector, we are just treating the common illnesses. What are the common illnesses, and then we are providing them essential drugs where they are available, and mostly we are referring the cases to the secondary and tertiary care. In fact, there are many instances where the cases even don't go to the primary care level. Even for their primary care problems, they end up in the tertiary care facilities in the cities. If you see in Islamabad, Rawalpindi, Karachi, Lahore, and you do a survey of the cases coming up into the tertiary care hospitals, majority of the cases are those which can be dealt at the lower level, at the primary care level. So the first thing which I would like to emphasize is that we should think back, look back, and try to find out what actually is the real meaning of primary healthcare, and why instead of having a primary healthcare system in this country, we are still using a primary care approach, which is ultimately scientifically it is called as first level care. So the first level care facilities of BHUs and RSCs and lady health workers and community, these are all very important, but they only make a very small part of the original primary healthcare component. So primary healthcare is a concept where it's not just one service. It is the linkage of various sectors, multi-sectoral and intersectoral collaboration with non-health sector. So it is an amalgamation of health sector with non-health sector at the peripheral level, at the community level, and at the price and at the cost which the community can afford. So nowadays, when we talk about social health protection, when we talk about expansion of social health protection to all people in Pakistan, I am very hopeful that this is something which will be taken up by the primary healthcare advocates, and hopefully we will be dealing with the original primary healthcare concept, which was described in 1978. Not this very tiny, small primary care component of provision of drugs and common illnesses at a BHU. This is not the original which anticipated. Coming to the preparedness and challenges and beyond COVID-19, just imagine, I was discussing with Dr. Yasmeen Sabih Khazi the other day, a few days ago, and there is a very big concern for all the advocates of reproductive health, all the advocates of MNCH, and all the advocates of family planning. Why? Because we spent 30 years, 3 decades, convincing the population, convincing the women, convincing the men in our society to take the women to the facility for all its MNCH issues. So facility-based delivery was promoted, the facility-based contraceptive provision and different interventions were promoted. Antenatal was made a very critical part of our MNCH. And similarly, for all matters, we encouraged all of them that home delivery may not be that much of a safe. You should go to you should get yourself booked, and after the booking, you should go to the facility for a delivery. What has happened in COVID? In COVID, there was a disruption of all these services for almost 6 months consecutively in the last year. And the facilities were closed in the private sector as well, and the OPDs were closed in the public sector. So what has happened is there is a fear of hospital now among the minds of the same women, where we promoted them and we abolished those fears, and we made the facilities. We tried to make facilities women friendly and gender friendly, but unfortunately this COVID wave has again brought us back to the square one. And what is the square one? Now most of the services will be requested at the facility, at the household level, at the community level. So we need to think again how to make the visit of facilities more accessible, and how to convince our because in the COVID, the hospitals were taken as a risky place. The most riskiest place in COVID was a hospital. So whoever had a history of visiting a hospital had a very high chances of getting COVID. And I think Dr. Jawad will talk a lot more about specific to COVID and challenge and preparedness. I'm just talking about that the promotion of facility-based MNCH and all other reproductive health services. We advocated for that. We enabled, we trained a lot of doctors and nurses and paramedics for these services. But unfortunately, the COVID has given us a setback. And now the primary healthcare will again revolve around the community health worker, which now will become an integral part of the future primary healthcare. The home visit and home-based services will be the most important things. So I'll end here because there is a list of very competent and senior public health professionals with me, and I'll stop here, and later on if there is a question I will join back. Thank you, Shahid.
Thank you so much, Dr. Shahzad Khan. You raised very serious concerns regarding the primary healthcare and healthcare system in Pakistan. Certainly, we would like to know more about you, maybe before closing the panel. So thank you for setting the ground as well. So my next panelist is Dr. Rana Jawad Asghar. He is the Chief Executive Officer of Global Health Strategies and Implementers, a consulting company in Pakistan. He is Adjunct Professor of the Epidemiology at the University of Nebraska, USA. He is member of WHO rosters of expert in epidemiology and surveillance. He is one of the 6 Pakistanis to be selected in 70 years of the history of Pakistan for the Epidemic Intelligence Services by the United States Center for Disease Control. He has served in a number of programs for the survival of child and many other related areas. He has set up Pakistan's field epidemiology and laboratory training programs in Pakistan, and he is a regular writer on the issues of pandemics and other challenges. For example, during the recent past, he has produced Choking Skies, The Mysteries of Diseases, and many other articles related to the virus. And we would like to know from Dr. Rana what is actually this pandemic and what is the new variant of the Omicron, and how Pakistan should face this challenge. Over to Dr. Jawad Rana. We would love to listen to you.
Thank you very much, Dr. Saab. And I didn't know that we're going to discuss Omicron today, but I would be happy to discuss it a bit later. But I have prepared few slides on the topic of the panel today. So I'm gonna share my screen with you. So if you allow me.
Umair, please give control to Dr. Rana.
Okay. Everyone can see my slides at this moment?
Not yet.
Now?
No. So, is it on your screen?
It's on my screen and showing display. Let's see.
Umair, if you can look into this.
Sir, can we click on share, screen share?
No, I have clicked on it. Let me try it again once more.
Umair, I have sent you Dr. Jawad's presentation.
Just 1 second. Okay.
Yes,
maybe
now it is. Yes, done.
Okay, done. Okay. Okay, sorry about that. And I will turn on my timer so I stop on time.
Sure. Thank you.
So thank you very much for inviting me for this talk. And because it's about primary care, and I'm one of the proud primary care physicians. That's how I started my career. And the tie I'm wearing today is actually representing WONCA, which is a word organization of family doctors and family doctors associations worldwide. That's the only organization. That's how I started my career. I was glad that you invited me for that topic. So if we look at WHO's guidance on COVID-19 response for primary care physicians, it gives four major areas in which primary care physicians could do a good role. And that one was that to make an early diagnosis, that family physician, when a person comes, they can make an early diagnosis, and then helping vulnerable people cope with their anxiety about the virus. And I can tell you, once in the beginning of the pandemic, that was, I'm talking about March 2020. I experienced this myself, though I was not infected, but I was exposed, and I had, started feeling some of the symptoms. And I can tell you that it was a huge mental stress. Even a person who's a physician who knew about COVID-19 better at that time, better than many, but it has a lot of mental cost. So the primary care physicians who work very closely with the families can actually help patients to go through that mental stress time period in less stressful way, and then reducing the demand for hospital services. So these were like three main areas which WHO feels the primary care physicians should be helping in the COVID-19. But there is unfortunately a reality. And what I have picked two examples which I'm going to discuss today, that how the role of primary care has been minimized in last 2 years and actually last few years. And COVID-19 was one of the major reasons that the primary care physicians went to the back seat of this. So if we, Dr. Shahzad mentioned also this, that UHC, or universal health coverage, is a critical component of sustainable goals. Pretty much the WHO, United Nations, government of Pakistan, and other governments are all propagating it, supporting it, which is a very good thing. But if you look at universal health coverage, which was the way it was designed, it's not just about the hospital costs. It has like four major areas. And one is, as Dr. Shahzad mentioned, is about the reproductive health. And it includes family planning, antenatal and delivery care, child immunization, health-seeking behavior for pneumonia. And then if you look at infectious diseases, yes, there are treatments, but there is an issue of sanitation. So sanitation was the component of UHC. It was not just the health treatment. Again, non-communicable diseases, managing prevention and treatment of raised blood pressure, not just treatment, but the prevention, and just like cervical screening, tobacco. And then there were issues about surface capacity and access, and basic hospital access, health worker density, access to essential medicines, and health security, compliance with the international health regulations, which are IHR. So UHC, universal health coverage, means a whole set of areas which we needed to ensure that they are happening in countries, and their people and their populations are healthy and have access to essential needs. Sehat Sahulat card is just one example of universal health insurance. And what I fear is that universal health insurance has been, I think, wrongly misunderstood or given equivalence to UHC, which is universal health coverage. And every government now claiming that because their population has access, has universal health coverage or health insurance, that means they are providing their duties and they are taking care of their population, which is, I think, not true, as I have shown you previous slides, that you have to do lot more than hospital treatment cost. But my other question is that there is a huge amount of resources going to these programs, provincially and federally. And I'm questioning, and maybe Shahzad Saab or someone else on the panel can guide me on this, where this money coming from? Is it draining the other preventive health programs? Has the money, because if I look at the spending of other preventive programs like dengue, like, if we leave the global fund program separate, the other preventive programs, their funding has not been increasing over the years, if not reduced altogether. And so my other question is, how has been our spending on basic health units or rural health units? Even though they were providing limited facilities, but I think they had a bigger picture of UHC. So in the COVID-19 pandemic when came, unfortunately, again, funding went exclusively to tertiary care hospitals, for ventilators, for PHE, PPE, and other stuff. Laboratories were strengthened. I don't think that primary care, and I think it's still not part of COVID-19 equation. Think about what has been supported in last 2 years in Pakistan for the primary care physicians for the COVID-19. And if we look at the fundings, I think there will not be even spent pennies. So even if they had spent pennies of COVID-19 resources on primary care physicians, I would have been happy. But not even pennies have been spent on primary care. So what is the way out? And I think it's difficult, but we need to, at the government level, need to think and clarify in their mind that prevention is better than cure. And Pakistan cannot afford to pay for curative services, including Sehat Sahulat card or healthcare insurance, if simultaneously we do not invest on preventing programs. Because if you are not going to prevent on preventive care programs and just spend on health insurance, eventually, because people are getting more sicker, having more disease, the premiums will go up. And once the premium will go up, and then there will reach a stage where government will not be able to even pay that premium for the universal health insurance. So we need to not think about one thing on the cost of other, but we have to do all this work together and simultaneously. So what is needed? And I think number one, financial transparency on health spending. It's none. We don't know that if the fund, let's say our hepatitis program was allocated 10 million rupees at the start of the year or the fiscal year. What happened by the end of year? How much money was spent on hepatitis and how much it was diverted to something else? And then I mentioned balancing curative and preventing focus. And we need to rethink our whole system, which still today banks on curative size than the preventive care, and making primary care really a primary care. At this moment, it's nothing there. So with this, I will stop just to make sure that I close on time, and I will be available for questions whenever that part comes. Thank you.
Thank you so much, Dr. Rana Asghar, for this very informative presentation and highlighting the key challenges to Pakistan and the healthcare system. You focused that we should go for the preventive measure. Of course, that is the way for Pakistan and the other developing countries. And other you mentioned about the transparency and other things. Really, these are challenges to the Pakistan's health preparedness system. Thank you so much. Ladies and gentlemen, let me introduce. ये screen बंद कर देंगे? Okay. Yes. Thank you. So now let me introduce my third panelist, Honorable Dr. Yasmeen Sabih Khazi. Dr. Qazi is the Senior Advocacy Advisor to the Bill and Melinda Gates Foundation, and she has extensive experience of working with the international agencies and the key global partners on the health and the health challenges. She has been engaged in the management training from New York, Australia, and Germany on the reproductive health. She has expertise in RH in the country, and she is a strong advocate for women's health. Uh, More than 25 years, she's been doing this health and healthcare support to the societies. She has been associated with Packard Foundation since 2003, and now since from 2016, she's been working with the Bill and Melinda Gates Foundation in different capacities. Uh, she has achieved Prime Minister's Performance Award to Packard Foundation under her leadership in 2009. And then Ladies Fund Women Award, which has been awarded in 2013. Uh, she has been invited as expert speaker by the Dutch government to talk on Islam and family planning, another very important area, which is perhaps one of the key hindrance in delivering health and health services to the mother and child health. Along with so many other awards, she has been contributing tremendously in Pakistan and out of Pakistan. With this very brief introduction, of course, the profile is very rich. With this very brief introduction, let me invite Dr. Yasmeen Sabih Khazi to deliver her talk and share her presentation. Over to Dr. Khazi.
Thank you, Shahid, and thanks for the invitation and for making me the part of this very expert panelist. I'm very happy, and if you can share my screen. First, I would like to thank Dr. Shazad and Dr. Rana for setting the context for me. It's very easy to walk into my talk now because you have already laid the ground about reproductive health, about women's health, and how important it is in a situation like COVID. Will you be able to share my screen?
Yeah, just a moment. Omer, please share Dr. Yasmeen's. Okay, so it is there. Thank you.
So I hope you're not counting the time that is being taken to load my
No, of
slides.
course, please take your time, Dr. Kazi, because we know that you will be delivering something very important. Yes, it is there.
Yeah, please make it full screen. Thank you, and I'll let you know as we move along. So I would like to, I mean, in this few slides, I would like to just narrate the story which everybody is telling, that how we, after the COVID scare and the global scare and the countrywide scare, when everything was shut down, we started looking at family planning, reproductive health, maternal neonatal child health from the very beginning. And this is about what we found out and what we are recommending as a policy change, the gaps that we have seen during this pandemic handling. So please, next. So as I speak, I'm speaking about half of Pakistan, which is, if you look at an estimated population of 220 million, half of these are women, although our sex ratio is slightly skewed compared to the other countries. We have less women than men. And that speaks in itself about the volumes of gender inequities and the kind of, discrimination that the girls and women face, sometimes even before they are born, but in many cases, as soon as they are born. And this is a kind of a social impact that we are still trying to handle and tackle. So we started talking about that we need to start looking at women, the effect of especially the health access and services for women and girls, and especially on those who are doubly marginalized, because we feel that women itself are marginalized in terms of access, but in terms of those who have some, other added burdens, like women with disabilities, younger women, migrant women, and older women. And then, I'm also part of those group who are handling SRHR for women with special abilities. We don't want to call it disabilities, and I need to change that. But there are at least 33 million persons, and there are different definitions. How do we define that? and out of which 60% of women are women. So it's a huge number. So us and few of us who are championing for these causes, like Dr. Shazad was saying, he has been one of our brigadier also, and he has been with us. That how do we handle this entire situation? We work as a Gates Foundation. We are working with a number of leading players, the NGOs, and we started talking and working with them at least to see the communities that our partners are working at. How can we reach out? How can we reduce this, the huge gap of access? And how can we make sure that at least those communities where our partners are working, we're able to mitigate some risk? And then we realized that there has been no gender analysis, which has been done. Of course, everybody was thrown into this pandemic. But if you look at how all the emergencies are handled, we have found out that there is no gender analysis. Uh, um, for any pandemic and humanitarian crisis, although if you look at the impact of these crises, the women are impacted much more differently than men. Even then, there has been no intentional effort to start looking from a women lens that how this will and what the response should be. So like I'm saying, we have found out that how women and other marginalized groups suffer disproportionately due to unequal gender and power relations that determine access to and control over resources. So, there is a power tussle, and we know that women are much more behind, and that's why they are much more vulnerable and much more impacted if any humanitarian crisis is hit. Next, please. So what we started asking, because we have been working with NDMA, PDMA during earthquake, during all the floods, whatever has happened as a crisis, and we have been saying, please classify reproductive health and family planning services as essential service, because the moment you declare it as essential service, it remains a priority. You don't start shutting it down, as happened in the lockdown. But even in other emergencies, you make sure that these essential services are replaced or they are sustained at whatever level they bought. But despite of many years of advocacy and championing, when this pandemic hit, we found out that is still not the essential services. And it has been, they've been asked to close the family planning clinics because they think this is non-essential. And, so it has a huge impact. So all of us who are working on that, we started having this key advocacy ask. I'm very honored to be sitting in Chief Minister Task Forces on Population for both Sindh and Punjab. And of course, I was also made a part of COVID-19 response mechanism on MNCH and FP in some certain provincial governments. So we started asking for these, these policy changes. And we said that, you need, and this is very initial, of course, and then lateral connections were made that we need more maternal and neonatal and family planning experts in the national and provincial task force responses. Yes, we need infectious disease specialists, but to start looking at the multiplier effect. And then we felt the government is doing whatever they could, and they did it. I must give them the credit with full responsibility, but they cannot do it without calling in the private sector. So there were supplies issues, there was equipment, there were commodity issues. So there was a complete disruption, which is still not reinstated. Then please, make them partner. And then I've already said about the MA and PTMA policy where they are lacking. And then, of course, we have to find, evidence-based scientific information which should be properly disseminated on COVID-19 and women's health, because in the initial phases, we found that was completely missing. It was just about the virus response, which was, of course, the utmost need, but no lateral connections were made with the women's health. Next. So the one thing that has come out very clearly, and Michael is sitting here, the WHO has been talking about, and we are supporting as B&MGF fully to that, the women's self-care model, that how women are empowered and they can look after their own health issues. So, what women can get at home. We have the Lady Health Workers Program, and we have other community health workers through NGOs who are providing some basic contraceptive like condom and pills. But we demanded that we should have emergency contraception in that kitty, and there is a new self-injection, which is a subcutaneous Sana Press. So wherever it is applicable, it's only applicable in Sindh at the moment, but it should be part of it. So women would have access for continuation of her family planning and contraception needs. And then, of course, we came up with the guidelines which were exclusive for family planning and reproductive health. It was done in Sindh very quickly. I'm very happy to be part of the core group who did that. And we were asking all provinces and federal ministry to do the same. And then it should stay there. So the FPRH guidelines would also included gender-based violence, postpartum family planning, post-abortion care, and mental health services. So very rightly, when Dr. Rana was talking about, we found that the mental health issues are so important that we need to make it a part of all education and sensitization. And then, of course, we need the training not only for the, we need this sensitization not for the clients, but providers, because for them, these were the new information, how to align with that. So there was a lot of need that was identified and we were doing it. We were asking government to take the lead as well. And and I have highlighted and underscored it because we found that there was a lot of good efforts and goodwill across, but the coordination was lacking in the beginning, even among donors. So I represent a donor group, but I felt that we needed more coordinated effort. And I must say that many UN agencies and many donors come into play to do that. Initially, of course, everybody was doing their own bit. And even working through the partners, that how we come up with the new resource material and responding to the government need, you need to have alignment. So we don't end up doing the same thing and wasting the resources. Next, please. So I've already said that we have to revisit the policy documents for aligning with COVID response, the MNCAs, the reproductive health, and the family planning. We have, I'm sorry for this abbreviation, but Council of Common Interest Framework is a new roadmap for family planning, which was approved in 2018 under chairmanship of Prime Minister. We thought its costing is important, so it could improve the disaster management as well. And of course, our standard ask for health and family planning budgets to be increased. We thought there is a new normal because even now, with everything that is not taken away, the social distancing and very strict, vigilant infection control prevention, and the questions that women have, because they may say, "Oh, can we take oral pills if we have had the COVID?" And so there are new questions, there are new responses that needs to be devised. So we need to work on that. And then, of course, the young people voices. We should never forget that Pakistan is passing through the demographic dividend. 65% population is below the age of 30 years, and we keep forgetting about the young people. So that is extremely important. As a donor, we have seen that there's a lot of repurposing of budget, which was done by the government and donor themselves. And the first thing that was mercilessly cut was the family planning services. Pakistan has one of the highest burden of unsafe abortion in the region. 2.2 million women undergoes abortion. This was a decade ago. We don't know what's happening now. So we cannot let this happen. Family planning and reproductive health services needs to remain, intact. And then, of course, we feel that from an accountability perspective, the communities and the NGOs can play a great role. And then I've already said that how we align family planning messages with COVID messages. So entire social behavior change communication needs to be redesigned. Next. So I've already done this presentation, but I just pulled it out to show that even at the global level, because I'm sitting in the global level also in few of the advisory group, which is on gender and COVID-19. And we found out that when the clinical research trials were started on vaccination, it completely ignored, so it's not Pakistan, on the sex differences, disaggregated data, inclusive and intersectional research. And the global experts called it, the vaccination is 91% gender blind, because only 29% principal investigators were women, also lacking equity in leadership of trials. And what was missing was the epidemiological data by sex and age, which was not considered in trial, neither routinely analyzed. One example is the pregnant and lactating women. They were not included initially, they were included lately, and that there's so much confusion. Still, the women who are pregnant or who are lactating, they're not sure if they should have a vaccine. So, so, and then, when you're planning and deployment of vaccine delivery, which we have seen in Pakistan, has to be gender sensitive, because still WHO gives us this after every 2 weeks a briefing, and we have asked to have that sex differential, incident, evidence, and they said still, like, women are much less than men who are getting vaccinated in Pakistan. Next. So this is about the gender sensitive equitable rollout, that we want really end-to-end lens on COVID-19 vaccination, equal participation in decision making by women, having women leaders, having them at the table, and looking at the gender related barriers, that why women are not being included, having those M&E indicators to check on that, and then of course ensuring the messages are right based and do not reinforce the stereotypes, and then why women are analyzed. Until we don't start looking at these questions, nothing will change. So there has to be an intentional inquiry. And then we know that there are a lot of known unknowns. So transparent communication is required. Next. So I will not repeat it because I think I have said a lot of it. But I would say that the customized SBCC campaign, which I've said is going to be the need of the time going forward. The public-private partnership model, we note that we need to start looking at CSR funds and the corporate sector, and then we need to see that how can we handle the provider biases, the biases in the system, and we continue to have gender-released disaggregated data, and going to the last mile of vaccination, which government has started, but it cannot be done without community-based organization, NGOs, and youth groups. Next, please. So these are my last. This is my last slide, and these are the kind of my, broken record messages that I keep giving. But I thought that it's important that invest in girls and women. The return on investment is unprecedented. So whether it's a girl's education, preventing girls from early marriages, providing them access to reproductive health as early as possible, you have to start investing on girls and women. And then ensure that health and family planning budgets are not compromised due to other priorities. This should remain an essential budget line under all circumstances. I've already said about that how important it is to engage young people in program design and invest to reap demographic dividends. Accountability by community is one of the best measures to reflect on health system response capacities. We are very scared of accountability, but I feel that this is the best way to really look back and see that how we are doing and what our response should shape. And then the roadmap for right-based, high-quality, accessible, and affordable family planning services is through health and population integration with scaling up family planning and health system. This is a systemic flaw. Our health and population ministries are vertical, and that's why we lose so much. So these are my other, that remember, cost of inaction is much higher than the cost of action. We keep on hearing, oh, we don't have budgets. They don't realize not investing in reproductive health, MNCH, and family planning could result in a much higher burden on the health system. Then act now before it is too late. So we have to start working now. And this is, I think, our WHO leadership who keep saying no one is safe unless all of us are safe. So it's not about just me and you, it's about all of us as a community. Thank you so much. I think the last slide is about thank you. Thank you, Shahid. So I overstepped sometime, but
yeah, thank you so much, Qazi, for highlighting the key concerns related to mother and child health and FP and RH related issues related to youth under age 30. Thank you so much for highlighting these points. Ladies and gentlemen, we have next speaker, Dr. Adela Rahman. She is PhD in Sociology from International Islamic University, Malaysia, and Masters in Gender Studies from Fatima Jinnah Women University. She has focused on behavioral health and working on its own model, caring for cure. It's a mental health network, and she has been part of University of Texas, Austin, USA. She has delivered a number of lectures in different countries on health, medical sociology. With this, currently she is working as a professor at Fatima Jinnah Women University, Rawalpindi, Pakistan. So with this very brief introduction, I'll invite her to share her research with us. And so if you can, Dr. Adeela, please keep yourself around 8 to 10 minutes. Thank you.
Sure. Thank you so much. Thank you so much, SDPI, for inviting me and giving me this opportunity to share my research. I will try my level best to be a brief. Okay, Jay, today I'm going to talk about the psychosocial well-being of COVID-19 affected families and coping strategies for sustaining familial relationship. As we all know the effects and the aftermaths of COVID-19, I'm not going to discuss about what COVID-19 is. I'm going to talk about the familial relationship affected by COVID-19. Being a medical sociology and a sociologist, whatever the sector is most affected was the families. The families who were affected with COVID-19 and the families who were suffered with COVID-19 with the death cases. And that was a very big trauma for the families, and how they cope up with all those traumas, that is important to understand. So previous researches were not talking about much on that particular family relationship. So therefore, in this research, we focused on the daily life experiences of COVID-19 affected families and to explore the coping strategies adopted by the affected families and what are their experiences encountered with the deaths of their family members. There was a few gaps in the previous researches conducted during the COVID-19 pandemic. Even in 2020 and 2021, they were not focusing on the social and familial relationship. So therefore, it took interest for the researchers like me to focus on that social relationships. So qualitative research were conducted in which in-depth interviews were conducted with the 6 individuals from 3 COVID-19 affected families. These were those families where they faced the death as well as the COVID-19 affected patients, and they perform both as a patient as well as a caregiver roles. The families were selected through snowball sampling from Rawalpindi and Islamabad. The data collection procedures was conducted by using interview guidelines. The particular questions we asked: what were the main psychological feelings of care providers for COVID-19 patients? What were the coping mechanism, and what were their insights in the face of epidemic? In addition, following sub-questions were asked: how do you feel when you're working with COVID-19 patients, and how do you cope with the changes in the work life? So the findings indicated that social stress, fear of losing close family members, and social
Adeela, you
disruption.
can change your slides here as well.
You can't see my
Only
slides?
title slide is there. Only title slide is there. So
Oh,
other slides are not moving along with your.
okay. Let me again share. Can you see now the
Yes, now.
findings? Okay,
Yes, sir. Yes.
so I'm sorry for that. The findings, the results highlighted that social stress, fear of losing close family members, and social disruption of daily life among both the affected and caregivers were noted by the respondents. Respondents also face stigmatization, like people call that this is a corona home, people should away from that home, and also patients were affected that due to them, patients feel guilty that due to them their families had to suffer with the virus too, or managing family relationship. Individuals who are affected by the virus or experienced deaths in their families were more depressed and scared of COVID-19. Furthermore, their impact of COVID on health, we can identify that they suffer from mild to moderate respiratory illnesses, dry cough, fever, fatigue, shortness of breath. Every individual face different kind of symptoms. According to the caregivers, reoccurrence of disease symptoms after partial relief, reversal of the symptoms, and the appearance of unexpected symptoms cause them to feel hopelessness. As one of the respondents quoted that, my husband's fever stopped for a few hours, but I did not know whether to help or not because the fever started again, and this happened over and over again. Sometimes he was feeling good and sometimes he was feeling bad. Such fluctuating symptoms bother them a lot. Furthermore, role of caregivers were mentioned. The situation was also panic due to the inability to establish close interaction with the affected family members, particularly in case of deaths. All participants considers lack of knowledge and care skills as one of the main problems in caring for patients with COVID-19. Most caregivers expressed that they doubted their ability to care, their information needs were not met, and they feared that this lack of knowledge and skills would cause harm to the patients. Despite all those lack of competencies, the ample support and ample social support was provided to the affected individuals as precautionary measures to get rid of their psychological concerns. As far as psychological well-being is concerned, the psychological experience of caregivers at home is summarized into two themes. The first, the negative emotions present in early stage consisting of fatigue, discomfort, and helplessness was caused by the fear and anxiety and concerns for the family members. Second, self-coping styles including psychological and life adjustments, artistic acts, family support, and rational cognitions were also noted. The paper concluded that COVID-19 not only impacted on human health, particularly in healthcare system in general, but also the whole society and every sphere of life affected. Social capitals plays an important role in overcoming the negative influence of COVID-19 on human being as well as an individual and society as a whole. Findings also highlighted that even in worst time, social support can become the lifesaver for the affected people. Furthermore, social relationship can stay healthy by using different coping strategies like respondent used in their suffering time periods, such as reading, learning, and using spiritual ways to heal the pain. The final recommendation is the study recommended to strengthen, we need to strengthen our social capital among societies to provide ample support to each other during such pandemic. And at the state level, social support group and psychological counseling centers should establish to support the affected families. With this, thank you so much.
Thank you so much, Dr. Adeela, for sharing your research study and findings, and very special thanks for being within the time range limit. So obviously, at the end, we'll be requesting to Dr. Shahzad to talk about the comparison between the research studies and the ground realities of primary healthcare delivery system. So, but now let me invite Dr. Saadia Mustafa. She is consultant family physician and women health specialist. She is member of Royal College of General Practitioners and Royal College of Obstetricians and gynecologist. She is leading family medicine department at Health Services Academy, where she is involved in capacity building of general practitioners. She has also conducted some of the research on the COVID in the COVID context, but she has also worked on mother and child health, and we would listen to her for her contribution in MNCH and in the context of COVID scenario. So over to Dr. Saadia Mustafa.
Thank you so much, Dr. Shahid, and thank you very much, SDPI, for giving me opportunity to present here today. A lot of what I want to say has already been covered by our seniors, Dr. Shahzad, Dr. Yasmeen, and Dr. Rana Jawed Sahab about the importance of primary health care and the effect of COVID-19 on MNCS services that we saw with the pandemic rolling out, and how the snowball effect caused further problems. So let me just try and share my screen if I can. You see my screen?
Yes, it is there. Thank you.
Great, thank you. I'm working in Health Services Academy in Family Medicine Department in capacity building of GPs. Obviously, at primary healthcare level, The MNCS services is where we focus most on. The work that I'm going to present today is what has been done in HSA in collaboration with its partners, and has been a part of health and population think tank, and the report that came out from HSA led by Dr. Nabila Zaka about improving maternal outcomes, maternal and child outcomes in countdown to 2030.
Please move to the slideshow. Yes, it is there. Yes, it is working. Thank you.
Yeah,
yes.
Okay. Right, let me just move to the slideshow, actually, that will be better. Right, so just a brief, it's already been covered mostly, but what we want to say is that Pakistan doesn't come from a brilliant health background. Pakistan is a population of 232 million, where global life expectancy is 73, but in Pakistan in 66 years. So we are already before pandemic starting with not brilliant health indicators and health outcomes. There is a huge proportion of children under 5 and women of childbearing age that are particularly were affected by COVID-19 pandemic. So every hour in Pakistan, there are about 750 children are born, and one mother dies during pregnancy, and more than 50 children die before their 5th birthday. This is a huge, huge loss of life compared to when we look at some of the other nations in the region. Although the maternal and child mortality has come down with time, it is still significantly higher than many other comparing countries. So what happened in COVID-19 and MNHCS services, as Dr. Yasmeen mentioned, as Dr. Yasmeen mentioned as well, is that there's already the health system is stretched, the resources are scarce, and availability and accessibility of health services was poor. What happened with COVID is it pushed it further back, and the direct effect of it was felt on MNCH services. So while people can stop going to doctors for their routine medical checks, the pregnant woman the women will still carry on getting pregnant. The babies will still keep on being born. So these are the things that the services. These are the areas that still needed continuous care. However, these are the areas that felt the most effect of the services being taken away. There was diversion of available resources, including the financial infrastructure, logistics, due to being diverted to the other areas for COVID-19. And obviously, RMNCH was the first one to compromise. It's quite lower down in the priority list. So because of these lack of resources and the lack of confidence on continuity of care in both public and private sector, we saw the indicators going down further. So these are the statistics from February 2021, where 33% of total COVID cases were female, and out of those 33%, so out of those total COVID cases, around 21% of women were actually the women of childbearing age, including pregnant women. So although we know that COVID didn't affect children as much, but again, there were a lot of children still affected, and with a little bit of disproportionate effect in different parts of the country were seen as well. So just to look at, and this is a data from GHIS that was collected by the government and was presented in our HDTV meeting, was how COVID actually affected MNCH services in our countries. So if you look at right is the COVID times, and the left side graph is the year before in 2019. So starting from actually the reporting, so the reporting went down. So actually, we don't really know what was the actual impact, but we are just relying on the data that was actually being reported during that time period. So all the OPD attendances by women and children went down in COVID times. Number of antenatal visits, So the routine antenatal care, the women coming to hospitals for that or the primary healthcare centers went down. After being born, the postnatal care to women and newborn, women coming for that came down. So the number of deliveries in the healthcare facilities came down, which means a lot of these births, so the births were happening, but they were now happening at not in the healthcare facilities. So actually we don't really know the full impact of what was going on and what were the outcomes. But we knew that the healthcare facility births went down. And similarly, because these people were not coming to hospital, we saw actually paradoxically a fall in the respiratory illnesses in children because these children were actually not being brought into hospital. Similarly, the uptake of vaccination came down as well. So overall, we saw in all areas of MNCH, we saw a decrease in the coverage in the COVID-19 pandemic. And this is, we think, is an underestimate of the actual problem. So the family planning services, antenatal, delivery care, newborn, breastfeeding, vaccination services, child health, nutrition, all these were significantly decreased during our time when we looked at that data. So just an overview of how the healthcare system works is the level 1 and 2 that was so stretched and broken down that, that people were not getting to then further levels, and all the referral system was broken down as well, having a direct effect on these outcomes. So we have talked a lot about UHC, universal healthcare, and its essential health package covers for RMNCH point of view, these 12 major components, and each and every one of these are very, very important. And particularly we have talked about family planning services as well. So what are the key challenges? Obviously, we know that our healthcare system is poorly funded and sadly poorly governed. There is inadequate and inequitable access to universal health coverage, and the quality of care is patchy and is not consistent. There are less number of doctors, nurses, and qualified healthcare professionals, and we saw this number going down further in COVID times because of the hospitals shutting down, lack of supplies, doctors or healthcare professionals not being able to work because of lack of PPEs. Then there are frequent health emergencies. Our healthcare system recovers from one thing and then
Dr. Saadia, if I may request you, please, within 2 minutes, 2 to 3 minutes, if you can finish.
Yeah, we just finished it. And then, so again, we have already discussed this key priority areas for MNCH. We need leadership and coordination mechanisms. We need to prioritize our MNCH and then to be able to implement that at a grassroots level, working along with our partners, particularly private sector, which is a particularly strong healthcare sector in Pakistan, and also to target where it's needed most, i.e. poor and rural communities and uneducated masses. And again, tackling the health workforce crisis, improving the doctors, nurses, midwife, healthcare workers ratios, and then developing the system for timely referral of these cases from doorstep to the facilities where they can be looked after better. And most importantly, to be able to collect the data and to be investing in information systems so that we can actually capture the full extent of the problem, and also to be able to understand and direct our resources for future. Thank you.
Thank you so much, Dr. Saadia, for sharing your research and talking about the mother and child health and challenges. So, ladies and gentlemen, now let's move to the next panelist. before going to the analysis, Dr. Mumtaz Ali Khan. He is the senior scientific officer at National Institute of Health. National Institute of Health is very actively playing and performing its role in the context of vaccination and the COVID-19 scenario. So I personally has the honor to visit him and to show some of his work. And we would like to know about the vaccination, the challenges in Pakistan, and how it is contributing to improve the overall healthcare delivery system, what actually NIH is doing. So, Dr. Mumtaz, over to you. Please share your thoughts and your work regarding this vaccination and COVID-19.
Thank you so much, sir. I will go briefly slide to slide because this is really a huge topic, but I will try to cover within speculated time. Let me start the slideshow. So I will be talking about these three topics briefly: operational challenges in the early days, response at point of entries, because these were very important in the early days and even still, and COVID vaccination. So, Pakistan could be a potential hotspot for COVID-19 owing to its high population and its struggling healthcare system and economic system. Pakistan was able to tackle the challenges with relatively mild repercussions. The world health system was another challenge, resulting in poor coordination across the sectors. COVID-19 pandemic started in Pakistan, and we had first case on February 26. We reported from Karachi. The cases were reported from Karachi and Islamabad, and then it created a great panic because we were sandwiches in two epicenters, Iran and China. Early operational challenges were many, and a few are listed here. Pakistan was not prepared in terms of capacity to detect, respond, and prevent such novel virus outbreak. If we pick up, Pakistan was proved to be the backbone of these operations because many of our fellows trained workforce were present in provinces and also in the point of entries. Quarantine centers and isolation rooms were a new concept for administration and general public. Pakistan had few quarantine centers at few point of entries like in Karachi, but were not equipped and regularly used. We had few isolation rooms in major hospitals in the country. And likewise, the diagnostic capabilities were nearly limited. Like NIH was the only center who was capable to diagnose novel viruses. So what the government started trainings, and during these trainings, NIH, Health Services Academy, Central Health Establishment, and provincial health departments conducted extensive trainings and simulation exercises throughout the country. HSA supported in development of training modules, manuals, SOPs, and guidelines initially, and partners like WHO, CDC, Public Health England, and GHSI supported these training activities across the country. Keeping the limited trained manpower at point of entries, the government deployed extra manpower from other institutions and trained all the staff across the country. The 15 point of entries were operational nowadays, and even that time enhanced the IPC capacity and selected major hospitals countrywide. And also we trained the staff on sample collection, transportation, and packaging, because this was a new virus and everyone was scared about self-safety. These are some pictures from the training activities we conducted initially during this pandemic. Fortunately, at NIH, the public health EUC was already established in 2018 and was used for dengue outbreak in 2019. And this was great experience, and we activated this EUC for COVID response as well. So the public health EUC at NIH was the center of operations, and accordingly, when COVID cases detected at China, public health EUC was activated on 21st January 2020 and deployed coordination mechanism. And also we deployed extra staff from the other departments of the institute. This was the structure of public health EUC we established during January and February, and with the role and responsibilities and also the functions of EUC. FLTP workforce, as I mentioned already, we have completed 12th cohort, and now we have 13th cohort of this course. And as Rana Jawad mentioned, that he was the pioneer of this FLTP program. And thanks to FLTP, we had more than 220 CDC certified field epidemiologists and more than 300 frontline workers in the country. FLTP trained workforce develop initial contact tracing epidemiological services and response at local level and engage in rapid response activities throughout the country. NIH and FLTP developed these guidelines and SOPs. These were available and are available as well on the website of NIH for general public, for doctors, and for media. Then, keeping in view the burden of disease, the poor coordination because of this 18th amendment, the National Security Council established the National Coordination Committee, which was chaired by the Prime Minister with all provincial chief minister and Federal Minister. And then on March 28, 2020, the NCC decided to establish an operational arm, the National Command and Operational Center, to ensure effective coordination between the federal and provincial levels. And this civil military constellation has made a major difference in Pakistan's response to COVID-19. And indeed, it is a success story in Pakistan to cater and respond to COVID-19 like pandemics. And this was the structure, incident command management structure of NCUC. And it is really a lesson for us for the future outbreaks. These are the guidelines and SOPs available at the website of NCUC every time with update of vaccination and COVID patients. No doubt, polio UC played an important role during this outbreak. COVID testing facilities were only limited to NIH initially, and then was extended to the whole country. And nowadays, we are able to perform more than 60,000 tests per day at district level and also at private level, and also deployed mobile lab at Kaftan border for testing pilgrims and travelers from Iran. These are some pictures from the field response of NIH field sampling, and also now I'll talk about point of entries. Point of entries and an important part of this outbreak, because many travel associated cases are coming to spread virus in Pakistan and other countries. NIH, along with the Central Health Establishment and HSA and other health department, started this work initially and still working to train persons at point of entries. We established point of entry operationalized at Taptan, and also the Minister for Health of that time, Zafar Mirza, visited the operational situation, and this was another success story, and also deployed a mobile lab at Taptan border. This was the Pakistan House as quarantine for pilgrims coming from Iran. So these are some pictures from the training and simulation exercise of point of entries. I'm skipping few slides because of shortage of time. These are the screening data shows screened at point of entries at all major airports and ground crossings in Pakistan. These are the quarantine centers the Central Health Establishment has established at all airports. Almost 93% of the areas are covered. These are the isolation areas and provision of basic facilities. Some quarantine centers were established in hotels, and where their hotel were not available, these were established in tents on the ground crossing like Taptan border. Countrywide lockdown, smart lockdown policies, wedding hall, education institutions closure. These were the strategies performed during this outbreak, and also the risk communication. It was an important area, and Pakistan used an innovative method with the Pakistan Telecommunication Authority to have messages on mobile phone with every ringtone. This was another innovative area which helped us a lot. So I'll talk briefly about COVID vaccination. You know these figures. I will not go one by one. This is a vaccine statistic in Pakistan. Almost This is the global statistic for vaccination, and these are the situation in Pakistan. Almost 23.7% or 24% are fully vaccinated. This is last week figures. You can see these slides. 23% are fully vaccinated, and the rest 13% are partially vaccinated. We have good progress, no doubt. Almost 51 or 52 million people are vaccinated till date. You can see these doses. Pakistan is not very on the back seat. We are progressing. This is good news for us. And here, this we have to improve in this area, because Pakistan is 0.2 and 0.4, between 0.2 and 0.4. If we compare Pakistan with other countries around, Pakistan is really lagging behind, and we have to improve the vaccination status, because vaccine improves. Vaccine can help you from even from severe disease and deaths. If you see these two slides, which I have included from England and also from Chile, the fully vaccinated and partially vaccinated with booster dose and fully vaccinated with booster are protective, showing protective effect from severe disease and deaths. So we have to educate for vaccination. And I also started mobile vaccinations in Islamabad, and then urged the other provinces and other departments to start this. And also elderly and disabled people vaccinated at home. We also started production. This was really a good news for Pakistan, that we have our own perfect vaccine now. And also we started diplomatic vaccination, staff vaccination on 6th April 2021 on the request of Foreign Office. And till date, we have vaccinated more than 1,300 diplomats and embassy staff, and also we are providing children vaccination to the diplomatic staffs and also booster dose. These are some pictures from diplomat vaccination process in NIH Islamabad, and these are some major countries staff we have vaccinated. So thank you so much.
Thank you, Dr. Mumtaz, for sharing very informative a picture of the vaccination in Pakistan and the global perspective. So ladies and gentlemen, as we started a little bit late, and we'll try to finish this by 11:15. So we'll move 11 minutes beyond the scheduled time. So let me invite Dr. Shazad Ali Khan for his key recommendation or few points after listening all these presentation, and then I'll request to the chair, Mr. Michael, after Dr. Shazad Ali Khan. Dr. Shazad, over to you. Dr. Shahzad, are you there? I think probably. Okay, ladies and gentlemen, let's have the keynote speech, the final speech by the chair, Dr. Michael from the WHO. Sir, over to you. You have listened all these presentation, and we would like to listen the message from WHO and your views on this.
Yes, thank you very much, everybody. This is the keynote address that Dr. Palita gave me to read to the panel on. I'll exactly do that. That Pakistan is, we should know that Pakistan is the 5th most populous country in the world, with a population of over 227 million. That the public health system, the public health delivery systems functions as an integrated health complex that is administratively managed at district level. That the state provides healthcare through 3-tier healthcare delivery systems and a range of public health interventions. In addition, there is an extensive network of private healthcare providers comprising of for-profit and non-for-profit organizations. That the country also has a relatively large primary healthcare infrastructure, which includes over 5,000 basic health units, over 600 rural health centers, over 7,500 other first-level healthcare facilities, and over 100,000 lady health workers providing services across Pakistan. In addition to that, there is also a large team of vaccinators and community-based female healthcare workers. And then these primary healthcare services are supported by a network of about 1,000 secondary care hospitals at tehsil and district level, and tertiary care for teaching hospitals for referral. He alluded that despite all these structures, there is high population growth, there is an uneven distribution of health professionals, there is gap in healthcare infrastructure, there is insufficient or inadequate funding, there is fragmented health information systems, there is weak surveillance, particularly at the primary healthcare level, and limited access to quality healthcare services. He noted that conflict, disasters, and other crises in the country have had a profound effect on the healthcare systems and result in extremely grim situation. The impact of weak governance may result in generations without adequate access to social services and collapse of public institutions for health and welfare. That Pakistan is no exemption. The health systems in the country, like elsewhere around the world and the globe, have been confronted with a rapid increasing demand for services amidst the COVID outbreak. Maintaining population trust in the capacity of the health systems to safely meet essential needs and to control infection risk in health facility is key to ensuring appropriate care-seeking behavior and adherence to public health measures. That despite all shortfalls, the overall response of country health systems remains satisfactory. The government, with support from partners, has responded well to the COVID-19 pandemic through the establishment of structures for the response at all levels, strengthening case detection, contact tracing, isolation, quarantine, strengthening case management, crisis communication, and community engagement. That this support has been able to restrict the pandemic to a certain extent and has appreciated the knowledge globally. However, Dr. Paleta also noted that there is some areas for improvement, especially in establishing a robust governance mechanism through a well-designated mitigation and preparedness policies, strategies, and SOPs. There is also need to maintain or improve the level of coordination amongst the various administrative levels, different sectors, amongst partners, further strengthening the roles of bodies like the NCOC. There is need also to do equitable deployment of health workforce with skill mix. And then there is also capacity building of healthcare providers to deal with outbreak and other health emergencies needs to be thought of. For instance, improvement in case management, infection prevention and control, there's also need to improve the infrastructure and access to healthcare. I remember during these discussions, there's also need to rethink of the various tiers of the health service provision levels. There's need to strengthen the information management systems. There's need to think about the supply chain management before and during emergency. There's need to think about also community awareness and risk management. There is also room for improvement in promoting evidence generations and strengthening research. And lastly, the capacity to ensure sustainable financing and resource mobilization. Right now, a lot of money has been used to support the COVID-19. What next in future? Will we still have the same financing, or do we need to rethink about other means of funding health service delivery? Thank you. So this brief from Dr. Paleta in his speech.
Thank you so much, Honorable Chair, for delivering the keynote speech on behalf of Dr. Palita. We are really thankful to WHO for its continuous support to Pakistan and the people of Pakistan. And thank you very much for making key recommendation and points. For example, establishing a robust governance system, improving SOPs, coordination among partners, equitable and skill-based health force. Excellent suggestion from your side. Ladies and gentlemen, thank you so much. Although there are a few questions, but I think the time is over. Let me thank to Honorable Chair, Dr. Michael, Professor Dr. Shazad Ali Khan, Dr. Jawad A. Rana, Dr. Yasmeen Sabih Khazi, Dr. Adeela, Dr. Dr. Adela Rahman, and other Dr. Saadia Mustafa, and Dr. Mumtaz from NIH. Thank you so much for your valuable thoughts, for your contribution to improve the healthcare delivery systems and the challenges which are associated with COVID-19 to Pakistan. So the time is over. So stay blessed. Thank you, and Allah Hafiz. See you in the maybe next time in another panel. So, sir. So this is all from our side. So thank you very much for joining us, and thank you for your time, for your precious time and valuable contribution to this panel. So stay blessed, and Allah Hafiz.
Thank you all, and bye for now.
Thank you. Bye.